Well, here we go. It's time to go inside EMS. I am your host, Chris Cebollero. Kelly Grayson is here as well. KG, can't do it without you, man. What's going on?
I appreciate it, brother. I just got I just finished my IBSC critical care transport exam. That was that was fun.
Yeah.
Like
How
like
long?
pulling toenails are fun.
How many questions are on that test?
135.
How long they give?
135.
How long they
Two
give you?
segments. I don't know. Well over 2 hours. Probably close to 3 hours, but I didn't take that long. But man, you talk about it was some tough test questions. When they say it challenges mastery of a subject, I don't think they're lying.
Yeah, I mean they're a little bit different tests, right? So we're
Yeah,
not testing, we're not testing at this lower level, man. This is really
yeah.
skill mastery that you have to be able to
Hmm.
get to. And I think that that's what makes this test and the community paramedicine test, as a matter of fact, um, really challenging for EMS providers. If you
Yeah,
want these certifications, you have really got to be at the top of your game to
yeah,
get
I
these
know. Yeah,
certifications. It's not just, you're going to go in there. I mean, same thing with National Registry, but this is truly next level stuff.
yeah, yeah. And that's the next one I'm going for is my community paramedicine.
You haven't worked in
So,
community paramedicine yet.
we have a community paramedicine program at my employer. The problem is the sole community paramedic or the guy that was doing most of it, they fired him. So it's it's on the back burner right now. They got a grant for it, but I think it went on the back burner with the transition. So they're trying to get that back up and running
Well,
soon.
let me know if they need any help, man. I'm happy
Yeah,
to guide them in the right direction.
yeah.
But, Kelly, today I think one of the things we're going to talk about is sepsis. And this
Good
is
topic.
something that's really, really important, right? And when we think about sepsis, it remains one of the top killers that we transport. And early treatment really saves lives, yet most septic patients don't roll with a
Yeah,
sign that says I'm septic. And we've got to be able to have the best knowledge or the best ability to try to really, and I said it all the time, to be the ultimate detective of the body, to really understand that there's something more that could be going on with this patient. And a lot of times we get into the habit of just treating the chief complaint. And a lot of times
yeah,
we're treating the chief complaint that we're being dispatched to, and we're not doing our due diligence to learn
yeah.
enough to say, what else could this be? What's the differential diagnosis? Last week, Kelly, I talked about when we were telling, we did, or whenever it was, we did the storytelling podcast. I told the story of missing that, diabetic challenge, and I
Mhm.
thought that it was a stroke, right? But we've got to be able now to challenge and talk ourselves into, and what else can it be? But we miss sepsis quite a bit in EMS.
Yeah, well, because the presentation is so varied, and I don't think many people realize how common it is. We see the number of sepsis cases we see in EMS are more than stroke and heart attack combined, and it is truly a time-sensitive illness as well. But it manifests itself in so many different ways. You know, you get altered mental status in a nursing home patient. It's going after you check a blood sugar, it's going to be sepsis if it's not blood sugar, and just about I would say the vast majority of the time. And the way it affects people different with each patient.
Yeah.
So it can be quite challenging unless you have a tool uh, to apply to look for the sepsis guidelines, which is what we do.
Yeah. And I think that one of the things that we've got to remember, and I kind of touched on it when we opened the show, was they're not going to say I'm septic, right? They're calling 911 911 for vague complaints, right? Weakness, confusion. I'm just not feeling well. Something's not right. And then mortality can climb 7, 8% for every hour of delayed antibiotics, right? So
Hmm.
think about this as a race against time, Kelly. So, and I'm going to kind of pull this out of you as the provider of the group. Every hour of delayed antibiotics increases the risk of death. And we have to be able to understand that we've got to move fast when it comes to sepsis. When you go into somebody's home and you look at them and they say, this person is sick, how do you take yourself down this line of saying, could they be septic?
Well, the first thing you look for is any source of potential source of infection. And with chronically ill bedbound patients, that's duh. It's just about all of those have some source of infection. If they have a Foley catheter. If they have any sort of artificial opening in their body, it's a route for infection. If they're chronically bedbound, if they're chronically ill, they're immunosuppressed. All of these things can be uh, risk factors for sepsis, but you have to train yourself to look for everything. That scene size up, vitals, history, and looking at your vitals in context of sepsis. You know, you say, okay, someone's got a respiratory rate, if they got a heart rate of 90 or better, we don't really freak out about it. If you're thinking of it in terms of an arrhythmia, it's not. But a heart rate of 90 or better, and people that don't have intrinsic cardiac disease is one of the sepsis the SIRS criteria. You know, breathing a little fast. They may not be breathing especially labored, but if they're breathing fast, that's another one of the criteria. So putting the things we find, the vitals, the assessment in context of could this be sepsis is something you have to kind of train yourself to do.
Yeah.
And I think in recent years, you know, the awareness of sepsis has gotten so much better that we're starting to get better at that.
And we have to look at it. I mean, again, why did you get called to the house? We got to look at fever.
Yeah.
We got to look at hypothermia. We got to look at tachycardia. You mentioned tachypnea, altered mental status, possible hypertension.
Yeah.
Don't think that they're going to have hypertension, right? So
No.
when we think about this from that standpoint, as you mentioned, I love the thought that you said, or the guidance you gave about vital signs.
Yeah.
What is causing the vital signs to happen? And I
Hmm.
don't think that we do that. I think we take a vital signs, we say, okay, it's a little bit low, okay, it's a little bit high. And then I don't think we get into the microscope to say, why is this vital sign? Why is this
Yeah.
heart rate? Why is this blood pressure? And I think that's the thing that we have to be able to watch out for. So when we think about this from an assessment standpoint, you kind of gave us
Hmm.
the overview. You walked in the house, you
Yeah.
gave us the overview. We kind of did our quick scan. Do they look sick? Do we have time? Do we got to get them out of here? But I'm a big fan of the pre-hospital test, sick versus sick, right? So
Yeah.
now when you walk in, and you start to put them on the monitor, put them on a pulse ox, you put them on an end tidal, you check for perfusion. End tidal CO2 says they're 25. So now take us through this process. What are you looking for?
Well, the first thing I'm looking for is number one, if we have to understand that the presentation for say septic shock totally different than what we were taught to think of shock. These people are often febrile, so their skin's not going to be cold. It's a distributive shock, and the skin signs for shock are not particularly there. We need to, so if we're thinking of instability in skin signs being one of those things, often we don't realize that they're hypotensive until we get around to taking a blood pressure after we got them in the truck or whatever. So we catch up, we're playing catch up at that point, but you have to be able to trend vitals early on, and realize that just because that patient has good peripheral perfusion, or their peripheral perfusion is not compromised doesn't necessarily mean that they're stable. That's what distributive shock patients are. They may have pulses everywhere, just none of them are good. Uh, the Look for tachycardia. Use your shock index to your modified shock index, not your traditional Allgauer shock index. Use your modified shock index to determine just how deeply they're shocky and how as a predictor of instability. Um, these things that I think that just you mentioned Q-SOFA and SIRS. SIRS is not useless anymore just because
No.
Q-SOFA is the flavor of the month, and Q-SOFA has some issues. It's not really a sepsis screening tool; it is a mortality predictor. So when we talk about Q-SOFA, I think they traded sensitivity for specificity. Um, so if you're using SIRS and your agency is using that and you're comfortable with those, keep on using them. QSOFA is useful, but it's not the be all and end all.
Yeah. Tell people what
Um,
that is, Kelly, who may not know what that is. So basically it's quick sequential organ failure assessment, but give
yeah,
give people a little bit overview what that is. They may not have heard that before.
I can't remember. It's
So
overall
it's
mental status, heart rate, and temperature.
Yeah, it's a couple things. So
Yeah,
respiratory rate, you want to look
yeah,
at
it's like
systolic
50.
blood pressure, heart rate, if you have the
That's right.
ability to
Blood
do,
pressure and heart rate.
yeah, if you have the ability A lot of people are using ice stats or they're using piccolos
Hmm.
in the field now. You can get liver function, you can get renal function. And then if I'm not mistaken, and yeah, anybody out there knows better than me, I think it's also confusion and altered mental status. I don't know what we're doing. We have an internet we can look on too. We could probably figure it out
We
as well,
probably
Kelly.
could. We
Yeah.
probably go
But
internet. What's that?
exactly. But when we think about this from SARS and from from a high sensitivity
Yeah.
standpoint, QSOFA really focuses more on the low sensitivity, but higher different specifics, a higher specificity of what you're looking at.
I think it's the opposite. It's greater sensitivity, but less specificity. Um,
I don't know. I think you're wrong, but you've been wrong before on this show.
but the thing is essentially they're still checking pretty much the same thing: heart rate,
Right.
uh, mental status, blood pressure. Um, all of these things are part of your SIRS assessment. Well, your SIRS is uh, heart rate faster than 90 in the absence of intrinsic heart disease, respiratory rate greater than 20, or minute volume greater than, I forget what that is, what the minute volume criteria is. Temperature less than 96.9, greater than 101.9. We can all assess those. And white blood cell count less than 4,000 or greater than 10,000. The, the point that everyone misses here, though, especially the BLS personnel, is that you only need two of those criteria to call a sepsis alert.
Hmm.
And we don't need uh, blood test to spot a sepsis patient the vast majority of the time. It's nice to have an ISTAT and be able to get a quick CBC, but it's not absolutely necessary.
Hmm. I just want to point out a couple more things that I think before we transition. Next, Kelly, I want to start to talk to you, think about your interventions. So think about those. But I want to give you this before we transition. Mental status changes, usually confusion or agitation, can be early signs of sepsis.
Yep.
Now, here's the problem. You come over my house on a Saturday when I'm not in a good mood, I'm going to have confusion and agitation, or at least agitation, right? So it doesn't mean
Yeah.
I'm septic. But when we start to think of vital signs, when we start to think about all these things, if we now have to be able, and now if we have to focus on a condition, it could be sepsis if there's confusion or agitation. So think about it that way. Also, cap refill greater than 3 seconds. There's a problem going on, mottled skin, poor perfusion. Consider sepsis in those instances again, but this is going to be with vital signs. This is going to be with you being the ultimate detective of figuring out, wait a minute, they got a fever. There might be something wrong here. So,
Yeah.
Kelly, interventions, right? Early oxygen, aggressive
Yeah.
fluid resuscitation. We know those are the keys. Even if we're suspecting, we want to be able to jump into that. And one of the things that you think about, sometimes they throw in a 30 milligram per kilogram, of using crystalloids within the
Yep.
first hour, hypertension, blah, blah, blah. But, bring us up to speed now. You're going into a sepsis patient. You've identified that there's a chief complaint. You've kind of wiggled it down like, hey, maybe they're a little septic here. What are you doing for this patient?
Um, well, first I'd like to talk when you mentioned the signs of shock, delayed cap refill and mottled skin. If you see that in a septic patient, that is the FTD sign, because most of our sepsis patients are hyperdynamic. You see a patient that's hypodynamic and showing those skin signs that are classic skin signs of shock, they're close to dying, and they are likely as not already decompensated on you.
Yeah.
But when we're dealing with our sepsis patient, temperature control, maintain their body temp. Remember that in the very old and the very young, their immune systems are not well developed in the very young and are failing in the very old. So hypotension is just as a reliable an indicator as a fever
That's a good
of
point.
sepsis.
Yeah.
So maintain a good body temperature, keep them warm, and your surviving sepsis campaign has given us the guidelines for what we're supposed to do. But in the medical community, that's still somewhat a matter of controversy. They say everyone gets 30 milliliters per kilogram boluses within the first hour, and you can't really protocolize something that affects so many people because
Yeah.
not everyone's going to fit that protocol.
Right.
For example, half of the people that we give fluid to support their perfusion cannot increase their cardiac output in response to those fluid boluses. You can give them enough to drown them in their own fluid before their blood pressure comes up. So one of the things that I teach people is to look for the signs of fluid responsiveness. Do they have pleth wave variability? Does their end-tidal CO2 uh, come up when you do a passive leg raise? Those people might respond to fluid. But I think if we're going to treat sepsis effectively, not affectionately, excuse me, if we're going to do it effectively, we have to not be afraid to move on to vasopressors pretty quick.
Yeah.
Um,
And you got to be
and
comfortable. You got to be comfortable that you're making the right choice here too, guys.
that's
And
right.
here's,
But they say, in the guidelines that if they don't immediately respond to fluid boluses, move on to the vasopressors.
I
And
do want to
we
hit you with this though before,
yeah.
you talked about IV, and usually we're taught in trauma, two large bore IVs, but sepsis is another one to consider two large bore IVs,
Hmm.
right? The same thing with somebody who's pregnant. If somebody's in active labor, you want to be able to give them as much
Yeah.
fluid as you can because it secretes in the same area as oxytocin, right? So if we can
Hmm.
oversaturate the body with fluid, it reduces the oxytocin, which is gonna reduce labor. But anyway, the reason I brought this up is for everybody out there to think about more fluid the better when somebody is septic. But I didn't mean to cut you off.
Yeah, and the problem is they want us to bolus 30 milliliters per kilogram of a balanced crystalloid, and saline is not necessarily a balanced crystalloid. It's balanced in some ways. Ringers is probably a better solution to give if you're giving large volumes of fluid. Um, Honestly, if you're giving large volumes of fluid to anybody, you need to have a really balanced solution like Plasmolite or Normasol. And some EMS services carry them. But they're hideously expensive. So remember that when you give a liter of saline to someone, that's the equivalent sodium content of 30 bags, single serving bags of Lay's potato chips. You make them significantly hypernatremic. You can worsen an acidosis or cause a hypochloremic acidosis with large volumes of fluid. So you have to make sure that the patients you're giving large volumes of fluid to can potentially benefit from it.
Yeah.
When we, high flow oxygen, now we've talked about high flow oxygen and how oxygen for everybody is not necessarily a good thing. I don't think that sepsis patients necessarily fall into that category anymore. Um, you can't be stingy with oxygen, even though they may not need non-rebreather mask at 15. Uh, Make sure you're keeping their oxygen saturation above 94%,
Yeah.
period. It is also absurdly easy to draw blood culture or draw blood for cultures when you start an IV. If that can save one step in the hospital,
Yeah.
that's quicker they get their antibiotics.
Right.
And the time to antibiotics is one of the major factors we're trying to bring down. So if you have the opportunity to start an IV, start two of them in different arms and get blood samples from each one and label so that they know which arm it came from and they can run their blood cultures from that.
Yeah. And one of the things we want to remember too is we want to be able to notify the hospital as quickly as we can
Yep. Sepsis
to,
alerts.
yeah, to make sure that we get good sepsis alerts. So when we get on the horn with the hospital, we want to let them know what we think. Even if we're wrong, just like we've done before. We need to be able to talk about they need antibiotics. They need antibiotics right away. If we have community paramedics in our system, that we can get them to get some antibiotics, and we can get a protocol that is going to work for us to get our hands on their stash. I think that would be a cool thing as well. But Kelly, I want to go ahead and get to the close. When we think about this from sepsis, the bottom line is it's the silent killer.
Yeah.
Clock starts ticking before you leave the scene. Quick recognition, aggressive fluids, oxygen, good communication with the hospital. It's going to make the biggest difference. But more
Yeah.
importantly, you've got to feel comfortable with what you're looking at. You've got to
Yeah.
be able to say, I've got a fever, these vital signs are weird. You got to be able to open up and say, what else could be going on here? And we're the ones that have to be able to grasp this and get our hands on it so we can now give it to the hospital to say, I think this person's in sepsis. But give us your closing thought and let's move on to next week.
Well, I think that the more experienced you are in your profession, the more comfortable you are with ambiguity. And the thing you have to remember with sepsis patients is ambiguity is pretty common. No two of these patients presents exactly the same, but they all do tend to have certain vital signs that are in common that will help you spot that sepsis patient. And remember that even as an EMT, you can call a sepsis alert and get things rolling much faster if you spot a sepsis patient early. So keep this in mind whenever you do any patient assessment, and keep sepsis in the back of your mind as a potential one of your differential diagnoses. The more we spot these in the field and start treatment early, the more lives we're going to save. But you've heard what we think. We'd like to hear what you think. What do you do in your system? Are you doing anything special as regard to sepsis alerts? Do you use SIRS? Do you use QSOFA? How have you improved outcomes in your patients? What kind of liaison do you have with the hospital, and how do you work together in improving these outcomes? We'd love to hear those thoughts at the show at ems1.com. And for myself and co-host Chris Cebollero, thanks for tuning in to Inside EMS. We're going to catch you guys next week.